Hello and welcome back to Curbside Ethics. I'm Dr. Stephen Bradley, your host. I am an anesthesiologist and medical ethicist. I realize I haven't really adequately introduced myself. I started putting these episodes out. Initially, this podcast was a supplement to the Black Doctors podcast, which is a different podcast that I am a host for and that I manage. I wanted to produce content specifically regarding clinical medical ethics. So I started doing an extra episode every week. It was entitled Ethically Sourced, a supplement to the Black Doctors podcast. In the last month or so, I decided to switch this out and start a completely different podcast so I can separate the two topics. And that was the beginning of Curbside Ethics. For my background, I completed medical school at the Howard University College of Medicine before going on to the University of Chicago Medical Center for my residency in anesthesiology. During my last year of residency, I was able to do a fellowship at the McLean Center for Clinical Medical Ethics. The fellowship was a year long and covered all types of topics in the realm of clinical medical ethics. It started with a summer-long didactic series where every day of every week of that first month, we were meeting with philosophers and parishioners, lawyers, physicians, ethicists, and really going through some of the deep down literature on the subject. We had monthly and weekly case conferences where we discussed different ethical scenarios that were going on. And the beauty of the program was it had perspectives from very broad ranges of life. We had physical therapists in our cohort, we had nurses, we had residents, we had attending physicians. The specialties represented were anywhere from obstetrics and gynecology to pediatric surgery to anesthesiology to internal medicine. And coming together, we were able to discuss different ethical scenarios that were presented. We also took turns covering the ethics service at the university and were able to help impact and make decisions, these complex ethical scenarios. So that's a little bit about my background. I just have this passion for medical ethics, and that stems from some of the time I spent working in the intensive care units and some of the situations that occurred there. Now today, this episode, the topic, I'm going to be talking about global COVID vaccine health equity. I mentioned this in a previous episode back when this show was called Ethically Sourced and compared kind of how developing countries were working with and living with this COVID-19 pandemic as opposed to more developed countries, and how there is a wide-ranging disparity in both the medical care as well as the liberties and freedoms that different countries have. I try to review a lot of the medical ethics literature that comes out, a lot of its opinion pieces, but these pieces provide a lot of perspective on different things to consider. This article was published in the July edition of the Journal of American Medical Association. It was published July 20th and 29th of 2021. It is entitled Sharing Technology and Vaccine Doses to Address Global Vaccine Inequity and End the COVID-19 Pandemic. The authors of this paper are Matthew Cavanaugh, he's a PhD out of Georgetown University Law Center. Lawrence Gostin, he's a lawyer out of Georgetown. And Madhavi Sundar, who's another lawyer out of Georgetown. This article makes some incredible points and kind of puts things into perspective. What I'd like for us to come away with is just an overall picture of where we are from a global perspective with vaccine inequities. We've looked at it a lot in the States, which communities are suffering more from COVID-19 and which communities are or have less access to vaccination. But let's look at this from a global perspective. In the US as a whole, if we compare our numbers of active COVID-19 infections or SARS-CoV-2 infections and the number of people with COVID-19, the disease, that are hospitalized, we have honestly made a lot of progress compared to where we are or where we were last year. The number of cases are declining in the States. We have very high numbers of patients and citizens that are vaccinated against COVID-19 or vaccinated against SARS-CoV-2. We have reached record highs and lows. However, in lower and middle income countries, that's not the case. The worst of this COVID-19 pandemic has actually shifted to the global south. So the Southeast Asia regions, Latin America, these regions of the globe represent over 75% of global weekly deaths. Currently, this is the end of July in 2021. Currently, Latin America has the highest rates of death per capita. Essentially, if we look at the data that we have, we can see that the pandemic is now wherever the vaccine is not. I'm going to throw out some numbers and I'm going to try to highlight the important numbers here. Approximately 1.2% of the global vaccine supply has been received by low-income countries. And only 14% of the global vaccine supply has been received by lower to middle-income countries. These countries account for almost 40% of the world's population. We can contrast that with the population of the United States, where over half of our U.S. adult population is fully vaccinated. If you recall, the priority initially was to vaccinate healthcare workers and individuals from vulnerable populations, individuals in careers that directly contributed essentially to the economy and for maintaining our standard of living. Over half of the United States adults have been vaccinated. In sub-Saharan Africa, they only have enough doses of the vaccine to cover maybe 18% of their healthcare workers and older or vulnerable individuals. What is the cause of this disparity in vaccination distribution? And this vaccine inequity is driven mostly by an insufficient supply and an unfair allocation of vaccines. Essentially, these powerful high-income countries like our own has pre-purchased enough vaccine for their own population and then some, sometimes up to twice the number needed to vaccinate their population. And this brings us to the COVAX organization, which is the COVID-19 Vaccines Global Access Group. This is kind of a nonprofit and a worldwide initiative that's aimed at equitable access to COVID-19 vaccines. It's a partnership between a couple different organizations, including the Gavi organization, the World Health Organization, and the Coalition for Epidemic Preparedness. So a couple of organizations kind of got together, and the goal is to provide equitable access to the COVID-19 vaccines to vulnerable populations to help end this pandemic. So through COVAX, this global initiative to procure and equitably allocate vaccines, unfortunately, it failed to secure enough doses even for its modest goal of covering 20% of lower income country populations this year. The company Pfizer agreed to sell COVAX only 40 million doses and has only delivered just over 1 million doses as of May of 2021. Again, the agreement was for 40 million doses, but only 1 million has been delivered thus far. In June of this year, the G7 countries, they all got together and decided to share 1 billion vaccine doses, half of which would actually come from the United States. This, however, represents only a fraction of the approximately 11 billion doses needed to vaccinate the world. What can we do to improve access to this vaccine to help other countries that are less fortunate, that are lower to middle income, start to fight back against this deadly pandemic? There's a couple things that this article lays out. One would be waiving intellectual property. This was actually proposed by the Biden administration. It was joined by other countries that together have sought to temporarily waive countries' World Trade Organization obligations to enforce intellectual property with regards to COVID-19 technology. This is just a proposal, and it's going to take a while for this to work its way through the World Trade Organization. This wouldn't completely remove U.S. patents on vaccines. However, it would give governments this option to allow local manufacturers to produce, import, and export SARS-CoV-2 vaccines, immediately increasing access. When it comes to this messenger RNA vaccine technology, there are over 100 patents, and there are many different patent holders. This blanket waiver, if it comes to the World Trade Organization, could help eliminate these complex regulations and facilitate the manufacturing of more vaccines. We have to remember that these COVID-19 vaccines were developed with significant public funding. They're also going to yield high profits for these companies. So there is an ethical obligation there to help increase the access to this life-saving technology. Giving different countries the freedom to produce vaccines could address both the market and the ethical failures that have been encountered thus far. As the pandemic continues to worsen in lower to middle income countries, a broad, simple intellectual property waiver that covers all intellectual property, including patents and trade secrets, and extends to all COVID-19 technologies is urgently needed. An aside, as the Biden organization and other countries begin to push for this intellectual property waiver, it may incentivize other countries and other companies to be more proactive about providing additional doses of the vaccine. In the wake of the Biden administration's announcement to support this intellectual property waiver, both Moderna and Pfizer-BioNTech pledged additional doses of vaccine to be made available to lower to middle income countries. So this threat of potentially losing some intellectual property may help inspire these companies to be more generous. In addition to waiving these intellectual property rights, we can consider and we must consider sharing technology and expanding manufacturing capacity. Just because we waived intellectual property doesn't mean that these countries have the means to reproduce this vaccine. When Moderna needed additional manufacturing capacity, it actually contracted out to a Swiss company and transferred some of their technology confidentially, and were able to make additional supplies of the vaccine and to expedite their development process. If we share technology more openly, we can enable manufacturers in Africa, Asia, Latin America to make more doses of the vaccines for themselves. The Biden administration has a leverage to incentivize sharing this technology because of the extensive public funding that was used to develop these vaccines. The Moderna mRNA vaccine was developed jointly with the National Institutes of Health in the U.S. The National Institutes of Health also owns key patents in its development. Operation Warp Speed allocated $2.5 billion to Moderna to cover development and clinical trials. The use of public funds should come with ethical obligations to share this knowledge for the good of the global public. Once this technology is shared, there are labs and institutions across the globe that would then be able to make components of these vaccines. There may be some concern for quality control, but again, this is a side issue. There are many global companies and government-run facilities with excellent records and strong oversight. And the World Health Organization's pre-qualification or emergency use can work out a process to ensure high quality and safety in the manufacture of these vaccines. A third way to address this vaccine inequity would be to reallocate the procured and ordered doses. As we're working on ways to increase the production, the fastest way to vaccinate high-risk populations globally would be to reallocate doses that have already been ordered by high-income countries. Of the COVAX's 2 billion dose goal for 2021, only 88 million doses have been delivered. Less than a third of this is forecasted to reach 3% of lower to middle income populations by late June. Vaccine manufacturers could give priority to lower middle income countries and their orders for the vaccine. High-income countries could donate more doses that have already been delivered and received. The MasterCard Foundation actually donated $1.3 billion to the African Center for Disease Controls for vaccine procurement and production. However, African countries still need access to these supplies. The U.S. has started to do something. In contrast, the U.S. has shipped over 350 million doses to the states out of the order for 1.2 billion doses. Globally, as of May, 34 different countries have donated doses, with hundreds of millions more pledged to COVAX. However, lower middle income countries account for 6.5 billion people. High-income countries have purchased 5.9 billion doses. Faster and broader donation strategies could help vaccinate healthcare workers and vulnerable populations globally. To whom much is given, much is required. It is incumbent upon these wealthy, high-income countries to consider their global partners and to pitch in for the global good. Until COVID-19 is eradicated or managed better on a global scale, we have not done much to move the needle in this deadly pandemic. In summary, when it comes to equitable allocation for the future of global healthcare crisis, there's 3 principles that this paper argues for. First, pandemics require this surge funding. COVAX was established rapidly without inclusive governance or sufficient funding. We need to source a robust financing mechanism, possibly being triggered by the World Health Organization when it declares a public health emergency of international concern. Second, we need to increase funding to address today's multiple pandemics, which build capacity for future response. Specifically, there's global funds fighting AIDS, tuberculosis, malaria. All these global pandemics that are being managed could use additional funding, and that would help set the stage for future novel pandemics. Finally, this temporary waiver in intellectual property doesn't necessarily need to be negotiated whenever there's a crisis. We could institute an agreement to share technology and allow countries to waive intellectual property in global public health emergencies and have this as a standing policy where it doesn't need to be negotiated in the face of a global pandemic each time. So what are your thoughts on global vaccine equity? Are we doing all we can to help our neighbors across borders? What more can be done? How do you feel about how the U.S. has handled vaccine allocation and distribution internally? Is it time for us to shift our focus externally so we can help the rest of the world open up? Thank you for tuning in to Curbside Ethics. I'm Dr. Stephen Bradley, your host. I really enjoy digging deep into these ethical dilemmas and looking at health equity and what we can do to improve the care that we delivered. If you enjoy topics like these, please subscribe, follow the show, share with someone else who may benefit from listening to this episode.